Hi, everyone. My name is Leslie. I'm a neurosurgery physician assistant. I specialize in skull-based neurosurgery. I'm just pulling up my notes. I wanted to talk to you about side effects, complications, things to be aware of after surgery at the base of the skull. And this is intended for anyone who takes care of patients after any type of surgery around the base of the skull. And I want to just show you a little bit about the base of the skull. This is a skull base. This is the anterior skull base, front part, also known as anterior fossa. This is the middle skull base. This is where the frontal lobes sit in the anterior fossa. This is where the temporal lobes sit in the middle skull base or middle fossa. And this is where the cerebellum sits in the posterior fossa. This right here is a cerebellopontine angle lesion, probably a vestibular schwannoma. So what we're going to be talking about is it could be transnasal surgery to the anterior skull base or middle skull base, or any craniotomy that we do towards the base of the skull. And what I'm going to do is I'm going to talk about it specifically from front to back, anterior to posterior. And one of the things that is most important to know about this is the cranial nerves come out of the brainstem and they go through the skull base to go do their job, right? So a lot of what we're going to talk about today is directly related to the cranial nerves. So let's talk first about the anterior skull base cranial nerve number 1. That's the olfactory nerve. Now, the olfactory nerve, olfactory bulb, think of them like two Q-tips. They lay right here at the anterior skull base. So any surgery that we do, whether it's a transbrow coming in from the side, we can make a big incision across the top of the head called a bicoronal incision, but we're making the bone opening here. The reason why we make the incision over the top is so there's not a big incision across the forehead. So anytime we approach the base of the skull from this area here, or through the nose, we can disrupt the olfactory nerves, either the actual nerve or bulb itself, or the little fingers of the nerve that come down through the ethmoid sinus and into the nasal cavity. So it's extremely common for patients to lose their sense of smell or taste after surgery. Usually it's transient, meaning it's gone in a couple days or a couple weeks. However, there is a possibility with some surgeries that the risk of loss of sense of smell or taste is permanent. Second nerve I want to talk about is the optic nerve. The optic nerve is specifically for vision, not movement of the eye, but just the actual vision. And vision is the way that we evaluate vision is kind of threefold, right? So there's visual acuity, meaning how clear you see. Then there's the visual field, meaning how much you see. Right? So if somebody has, let's say, a pituitary tumor that's pushing up in the middle of the optic chiasm, and it's pushing on those fibers that cross at the middle of the chiasm, that affects the peripheral vision, leading to a condition called the bitemporal hemianopsia. So visual acuity, visual field, and then not having to do with actual optic nerve itself is the ability of the eyes to converge, meaning the vision from the left eye and the right eye coming together and creating one field of view. If there is an extraocular muscle problem or a cranial nerve 3, 4, or 6 problem, the eyes aren't coming together, the patients can say that they either feel double vision or their vision is not right. So when cranial nerve number 2 is disrupted, either at the optic tract, optic chiasm, or optic nerve, people will usually say that their vision is worse or getting worse, or that they don't see as much as they used to see. Be like, I don't see over here anymore or over here anymore. So visual changes after surgery are extremely important to follow, because if there is, let's see, somebody wakes up from surgery and their vision is fine, and then a day or two later, they say that their vision is much worse, or they can't see out of their left eye anymore, it could be that maybe the patient's developing a hematoma that's pushing on the optic nerve, and that would need to be managed immediately. That's an emergency. It's not a threat to their life per se in that moment, but it is a threat to a neurologic function, and that's vision. The third nerve is a nerve that not only moves the eye, but it opens up the eyelid and it affects the pupil itself. So the way that you monitor the third nerve after surgery is if you notice that someone's eye isn't moving well, their eye isn't necessarily opening, and their pupil is not moving appropriately, it could be an effect on the third nerve. Now, somebody may go into surgery doing generally pretty well, but disruption of these structures after surgery can mean they go into surgery, perfect vision, perfect movement of the eye and the eyelid. They wake up from surgery and their visual acuity is a little decreased and their eyelid isn't moving. And that could be because the third nerve or the optic nerve was manipulated during surgery. And you'd have to discuss with the surgeon or the surgical team whether that's something that had to be sacrificed during surgery to remove a tumor, or if it's something that was just from manipulation that will get better in time. Endocrine abnormalities, very important regarding the anterior skull base. So the pituitary actually sits right at the junction between the anterior and middle skull base in an area called the sella. So it's through the base of the skull at the nose here, but it's sitting right down in the middle, underneath the brain, the middle of the base of the skull. And the pituitary gland is responsible for secreting a whole bunch of hormones that affect the way that our body function. So I'm going to talk about endocrine abnormalities in a separate lecture, but monitoring things like the ins and outs, how much someone is drinking and how much they're urinating, checking the hormones, those things are extremely important after any surgery on or around the pituitary gland, because endocrine changes can make patients very, very sick. And monitoring that is of the utmost importance. Another thing that's really important to know about the anterior skull base is oftentimes the frontal lobe needs to be retracted during surgery. Now, there's patients that prior to surgery have a significant amount of frontal lobe mass effect, meaning pressure on the frontal lobe, similar to, let's say, like a pillow, right? So if the brain, and this actually has a brain on it, if the frontal lobe, if you think of the brain kind of like a pillow, if there is a tumor pushing up into the frontal lobe, it's causing compression. And then once a tumor is removed, that compression starts to release and the brain itself starts to kind of go back into its normal spot. So anytime there's either mass effect, swelling before surgery, or retraction during surgery, what can happen is something called frontal lability. It's the frontal lobe kind of it's responding to the insult of surgery. And it could mean those patients aren't really in charge of their emotions or actions or behaviors. Patients can be very easy to cry, to laugh, be sad, happy, even inappropriate. There are patients that we've had that are just really like the most lovely, calm, even-keeled people, but then after some retraction on the frontal lobe and after surgery, they're just, very nasty and inappropriate. And that could be very distressing to our nursing team and to the family. But it is our job to explain that that is unfortunately part of the recovery process. And the patients don't mean it. They're not intending to be that way. They wish they didn't act that way, but they're just not really in charge of what's going on. So we reassure them that this is common for us. This is going to take time to get better. It can take several weeks for emotional lability from frontal lobe retraction or swelling to improve. Another thing that can happen after surgery near the anterior skull base is epistaxis, nosebleed. Well, if you're doing a transnasal surgery, having a nosebleed after surgery is pretty common, right? So the nasal passage, the sinonasal passage is filled with mucosa, similar to the inside of your mouth or like that you can see up in your nose. And during surgery, there's a lot of irrigation and fluid that we use, and it mixes with blood and those tissues ooze. So having nosebleed, ooziness, mixed with fluid, brown, junky stuff, that's all pretty normal after surgery, and it should just slowly improve over 2 weeks or so. If there is bright red blood that is pumping out of the nose, obviously we'd be worried that that is an arterial bleed, and that would need to be managed with cauterization, pressure, or potentially even embolization. Let's say somebody's having nosebleeds but didn't have a transnasal surgery. Let's say they had a surgery where we came in through the frontal bone or off to the side, and then for a couple of days after surgery, they're experiencing nosebleeds. We have to be very concerned that we possibly could have caused a dural defect, meaning a break in the dura that covers the bone underneath. So if we're coming in, let's say through here, and we're retracting up the frontal lobe, if there is a small break in the dura, that means blood and fluid can be coming through one of these holes and out of the nose. So if someone's having persistent nosebleeds, but didn't have transnasal surgery, we have to rule out that there is a CSF leak with a dural defect, and it's very important. Now let's move on to the middle skull base, this area here where the temporal lobe sits. Now the middle skull base, super high price real estate. And the reason why is there's a lot of cranial nerves that come out there that are coming from the brain stem and heading out in that direction. That's also where a majority of the vasculature comes out. That's the carotid arteries come out at the most front part of the middle skull base and give way to a lot of the branches of the circulation that feeds the brain. So let's start with the fourth or sixth nerves. So we talked a little bit about the third nerves. There are three nerves that give movement to the eye, right? So there's the third nerve, there's the fourth nerve, and the sixth nerve. Well, cranial nerves 4 and 6, 4 would be, let's say a patient is complaining every time I look down at my phone or when I'm walking, I get very dizzy or there's double vision. That could be a fourth nerve deficit. And again, manipulation during surgery or just swelling from surgery can cause double vision literally in any gaze. Fourth nerve would be down. And what you have to tell those people is when you're walking, it's best to actually move your head in the direction that you want. That way you don't get so dizzy or you feel like you have vertigo from having double vision. The sixth nerve is the lateral rectus muscle, and that's looking off to the side. So for the right eye, it would be looking right, and for the left eye, it would be looking left. And what you can sometimes see is the eye literally doesn't move in that direction. So you ask the patient to look to the right, but the eye doesn't move past midline. And same thing for this side. And that's important to know, because if you're taking care of a patient, and let's say you're always standing on the right side of their bed, and they have a right sixth, the exact spot you're standing is the most difficult for them because you're in their lateral gaze. So you can either move to the left side of the bed, or you can tell the patient, do me a favor, you have double vision when you look that way, and tell them to just move their head. So if they're looking at you or like kind of turning their head a little bit, it might be difficult. But if they actually move their head in the direction that they want to look, it takes away that double vision on that lateral gaze. We're going to then talk about the trigeminal nerve. The trigeminal nerve is the nerve that gives sensation to the face and the cornea. It also gives innervation to the temporalis muscle here. So one of the most common surgeries that we do is a microvascular decompression for trigeminal neuralgia. And that's where we take a blood vessel that is compressing the trigeminal nerve right near the brainstem. We peel the blood vessel off of the nerve and put like a little pad there. When patients wake up from this surgery, usually they're thrilled that their pain is gone. But because the nerve is now decompressed, the nerve often gives this a numbness sensation. So the exact same distribution, let's say someone had pain here and here before surgery, it would be very normal for this whole area to be numb after surgery. Now, facial numbness is an annoying feeling because it feels like you were injected with Novocaine and your face is numb. And so you don't want to, bite the inside of your mouth or your lip. But the most important thing about facial numbness specifically is to make sure that the cornea is not numb. If someone cannot feel their cornea, they could get a hair in their eye, a grain of sand, and it can lead to corneal abrasions. And the eye could, unfortunately, it could cause real problems. We've actually had people lose vision because of loss of sensation to the eye because they don't feel something in their eye, or they don't feel that their eye is getting dry. Most of us, if we left our eyes open for a very long time, our eyes would start to hurt because they get dry, but people who have decreased sensation don't feel that, and that can be quite dangerous. The temporal lobes, right? So we talked about if an anterior skull base surgery retraction of the frontal lobes can lead to some cognitive changes and emotional lability and things like that. Retraction of the temporal lobes can lead to speech disturbance, right? So the speech centers are in there. People can suffer from inability to understand speech properly or speak properly. And that you might notice patients have word finding difficulties, delay in speech, or just complete inability to understand speech, right? So what you want to find out is first, is it receptive or expressive? That way you can communicate with the patient properly. If you're looking at a patient and you say, raise up your right arm, You don't want to raise up your right arm and then point to their right arm, because they can then just mimic you. You want to look at them and you want to say, raise your right arm. Because if they raise their right arm, that indicates that they're understanding your speech because they did the action. If they don't do what you say and they're not following commands, but they're awake and alert, they're just not following commands, it could be that they're not understanding the speech, right? They might be talking gibberish or using wrong words, and that can be extremely frustrating, right? So understanding that when you retract or there's mass effect or swelling by the temporal lobe, that can affect speech. And generally speaking, if we operate, let's say, on the left side, if someone's right-handed, generally their speech comes from the left side. And then the same is true for the other. If someone's left-handed, generally the speech comes from the right side. So let's move to the posterior skull base. So the posterior skull base is where the cerebellum sits. And the cerebellum is mostly responsible for balance and coordination, understanding where you are in space, things like that. The nerves that come out in that area, first we have the nerve 7 and 8. 7 and 8 kind of come out right together. Cranial nerve 7 is the facial nerve, and cranial nerve number 8 is the vestibulocochlear nerve. There are patients that have facial weakness or facial paralysis going into surgery. And if they have that, it's extremely unlikely that it's going to get better after surgery. Actually, it can even get worse. What is actually more common is, let's say, like a tumor in this location right here. This tumor is sitting right near where the facial nerve is, and also where the vestibulocochlear nerve is. And when you manipulate the area around the facial nerve or the facial nerve itself, it's not uncommon for there to be facial weakness or even facial paralysis. Obviously, we don't want someone to have facial paralysis. So if it's a malignant tumor and we need to get the tumor out for life-saving reasons, we would tell the patient, we expect you to have a paralyzed side of your face from the surgery. But if we're operating on a benign tumor like a meningioma or a vestibular schwannoma, we'll often tell our patients that the goal of surgery is to remove as much tumor as we can safely and not hurt the nerve. And that can be monitored during surgery. So we would usually leave a little bit left behind, but even still, the patient might wake up with some facial weakness. And that facial weakness, if it's not so bad, it can be noticeable to the patient and maybe the family, but not as noticeable to the care team taking care of them. But when it's a little bit more advanced, it can actually lead to the eyelid not shutting. So remember, we talked about the third nerve. The third nerve opens the eye. The seventh nerve shuts the eye. So if the seventh nerve gets weak, the eyelid is not going to shut all the way that itself. It might be a little bit open. And then what can happen is the eye can dry out. So eye care is by far one of the most important things after a facial injury or facial manipulation. Eye drops during the day, ointment in the eye at night, taping the eye shut, putting a bubble over the eye to trap moisture in, keeping that eye healthy. And then also the same thing can happen with the trigeminal nerve. People, when their face is kind of sagging a little bit, people bite their lips, food spills out, they can't keep liquid in their mouth. It's extremely emotional and extremely frustrating for patients who suffer from a facial nerve weakness or paralysis, because you go through a big surgery and then when you can see these cosmetic changes in the face and there's so much concern about the eye, it really is, it's quite an emotional process to go through. Let's talk about the vestibulocochlear nerve. If a patient loses their hearing before surgery, that hearing's not coming back, right? Once hearing is gone, it's gone. It's extremely unlikely to come back if it's secondary to something like a tumor. People lose hearing for lots of different reasons, and the hearing can come and go. But if you lose hearing because of a tumor, it's not going to come back. If hearing is lost during a surgery, it's not going to come back. There are two parts to the vestibulocochlear nerve. There's the vestibular aspect of the nerve, which is kind of like, your balance vestibular, and then the cochlear part, which is the hearing. So if someone wakes up from surgery and they cannot hear out of that ear, and we know that hearing was lost during surgery, we're going to let them know hearing was lost during surgery. This was something that was discussed prior to surgery. You need to be aware of that when you're taking care of them, because if you're coming into the room and you're consistently on the side of their hearing loss, that's going to be frustrating to them because they're going to be turning their head to hear you. So anytime you're taking care of a patient with hearing loss, you want to know what side is their good hearing, and that's where you want to focus most of your speech. Also with walking and movement, when a tumor is removed away from the vestibulocochlear nerve, they can feel very off balance and uncoordinated for a period of time until there's that adjustment period. So even just sitting up in bed from laying down, sitting on the end of the bed, walking, feeling very much off balance, like a drunken sailor, that is pretty standard after any surgery near the vestibulocochlear nerve. So it usually gets better in time, and if it persists, oftentimes we send the patients to acute rehab to help them adjust, and vestibular rehab after surgery as an outpatient is usually pretty helpful. Cranial nerve number 9, the glossopharyngeal nerve. That would be, again, if they struggled with it going into surgery, they're usually compensating pretty well. If it's something that happens as a result of the surgery itself, of manipulation, that's very dangerous, right? Because that means someone might not be able to swallow food appropriately. They might notice there's a change in the sound of their voice, but specifically is the vocal cords. If someone, when we go to swallow food or liquids, the vocal cords, the area that goes into the trachea, it shuts to allow food to go down the esophagus. But if that nerve was damaged during surgery or before surgery, and that isn't shutting well, they're at high risk for aspiration. Now, one of the things that I've noticed is we may have a lot of rules in the hospital, right? So someone might be NPO. They are not allowed to eat or drink. They might be on a nasogastric tube because they haven't passed their speech and swallow test. But family members are like, oh, my loved one will be fine, or the patient feels like they're fine. I have seen more than enough patients sneak food or drink unsafely. So it's our job as people who take care of these patients in the hospital to make sure they understand how important it is to follow our instructions, because things like aspiration pneumonia, and death can be results if the care is not taken appropriately in relation specifically to the vocal cords. Cranial nerve number 10 is the vagus nerve. No real specific concerns in the postoperative patient. However, you're monitoring vital signs, right? So if someone becomes bradycardic, it wouldn't be uncommon if there was any manipulation that it can affect the vital signs, but that's something that we obviously monitor and manage appropriately in the hospital. Cranial nerve number 11, the spinal accessory nerve or accessory nerve. If someone comes into surgery with that, like let's say there's been a tumor over a long time that's been compressing that nerve, you might notice that that shoulder doesn't lift up, or they have a winged scapula. The muscles that supply this area get atrophic and very weak. People have a hard time moving their shoulder, or they don't have strength. But if it happens after surgery and that shoulder girdle isn't supported as well because of the loss of that cranial nerve, people will complain of like a frozen shoulder type feeling. Like it hurts, they have pain, they can't move it well. And it's because literally those muscles aren't working well. So we work on physical therapy, we work on range of motion and exercises using the muscles around it to help support it. Cranial nerve number 12, the hypoglossal nerve. Again, a lot of our patients who have tumors around this area, before we even operate on them, they might have a little bit of atrophy of the tongue or deviation of the tongue, and they've learned to compensate when they're talking or eating food. They have slowly adjusted to that deficit over time that they're doing really well. However, if it happens after surgery as a result, then that can be quite difficult. The sound of their speech, how they move food around, are they able to move their tongue to get food down to swallow? It can be frustrating, obviously, for speech, but also very dangerous if they're not able to swallow appropriately. Those are like the cranial nerves as we make our way through the nerves, like the olfactory and optic and such, and then along the middle skull base, and then the lower cranial nerves in the back. Those are things you should be aware of after surgery. And I would urge anyone who takes care of skull base patients to try and spend a lot of time examining your normal patients, the patients that don't have any deficits, because when you know what normal looks like regularly, sometimes when there's an abnormality and you can't necessarily pick exactly where it's coming from, you just know that something feels off, and we bring it up and talk about it as a team. And then we say, oh, this is something that, it's annoying and it's not dangerous, or is this something that can lead to something dangerous where we have to closely monitor this patient and let them know how to follow this. Other things that you should be aware of when taking care of a skull-based patient are generally a lot of the basic stuff that we would worry about or monitor for any patient having cranial surgery. And those are things like seizure, postoperative hematoma, wound infections, abscess collections, development of hydrocephalus, meningitis, development of a cerebrospinal fluid leak, pneumocephalus, and then things like DVT, PE, and pneumonia. So any surgery that we do where we operate, where we enter in the cranial cavity, in anywhere in here, we're generally giving post-operative seizure prophylaxis, meaning we know if we're operating near the brain, we can irritate the brain and the brain can seize. We don't want the brain seizing after surgery, because if the brain seizes after surgery, it's a significant delay to the recovery. And it's very difficult for patients to recover from surgery as it is, and especially on top of the fact if there's a seizure. Now, if we're operating in the cranial cavity, but it's below the tentorium, the basically cerebellum and down, those are not seizure provoking areas. So we generally do not use anti-epileptics. But seizures after surgery can be very obvious, where it looks like a full generalized seizure. However, it can be something as simple as a handshaking, smelling weird smells, feeling like a sense of doom and something's wrong. So anything that feels a little off the beaten path or out of the norm, it could be a seizure. We don't usually expect seizures if we're doing a transnasal surgery and we don't get into spinal fluid and it's a pretty straightforward transnasal surgery. We're not worried about seizures. We do not give seizure prophylaxis. However, if during a transnasal surgery, we're going up into the dura by the brain and we're actually getting into spinal fluid and there's some manipulation up there, then we generally would put them on seizure prophylaxis. So if you wonder sometimes like why they're on seizure medicines and why not, transnasal surgeries, not getting into CSF, and any surgeries cerebellum and below, we don't use anti-epileptics. Things to know if you're rounding on patients or taking care of patients. If you think a patient's having a seizure, focus on the ABCs. ABCs, make sure there's suction that you can suck. We don't want patients aspirating. You have access to oxygen, and then Ativan, and call for help, obviously. Things like postoperative hematoma, infection, pneumocephalus. It's normal to have some blood collection and to have some air in the head after surgery. We call those normal postoperative changes, and that's part of the surgical recovery. However, anytime there's an excessive amount of air or fluid or hematoma, and it's actually causing compression of the brain, that is something that we need to manage. If there's a hematoma that's causing mass effect and swelling, that might have to go back to the operating room for an evacuation. Infection would require antibiotics or potentially even a washout or abscess evacuation. And then pneumocephalus is pretty standard after surgery. There's going to be some air that enters in the cranial cavity just because it was opened. However, if there's a significant amount of pneumocephalus, air in the head, then we have to do things like, lay them flat, put on a non-rebreather with oxygen. We do sometimes worry if there's an excessive amount of air and it doesn't make sense, whether it's far out from surgery or it's getting worse instead of better. That would indicate that there's usually an opening in the dura and air is getting sucked in, right? So let's say we did a transnasal surgery, and a couple of days after surgery, the patient is developing worsening headaches, some confusion. They're not as spunky as they were a couple of days before, and we get a CAT scan and there's a lot of air. That would indicate that there is an opening in the dura, a dural defect, and maybe they're not leaking spinal fluid out, but air is going up. And that could be managed with a lumbar drain, where we divert fluid, spinal fluid, away from this area and put it in the back. Or we, generally speaking, would go back and put in some fat or fascia and pack the area. Because if there is an opening in the dura that's allowing air to get in or fluid to come out, just like something can come out, bacteria can make its way in, and that can be a risk for meningitis. So the things that we need to prepare for to prevent things like that, like how do we prevent a spinal fluid leak? Anytime you operate through the nose, base of the skull, anterior, middle, or posterior, it's possible that there's a tiny hole in the dura that we don't see, despite our best efforts. and fluid can leak out. It can find its way through the nose, through a surgical incision. You can get a collection of fluid underneath the skin, and that could be a CSF collection. Sometimes we manage that with lumbar drain. Sometimes we have to go back in and revise. Oftentimes things like steroids can help, but usually if there's a spinal fluid leakage, that would need to go back to the operating room for revision. So anytime you see fluid leaking from any, whether the nose or the wound, we have to make sure it's not a spinal fluid leak. Okay, development of hydrocephalus. The brain makes spinal fluid at the same rate that it absorbs it. So, me sitting here today, I don't have anything going on in my head. My brain is making spinal fluid and it's absorbing it, and nice and clean like water. Okay, after we operate, we open up the head, there's blood, there's proteins, it kind of gets mucked up, right? So the brain is continuing to make spinal fluid, but it doesn't absorb it at the same rate. It's almost like your gutters get clogged. So depending on the type of surgery, usually the brain just adjusts, and most people do very well. However, sometimes what can happen is we know the pressure starts to build up, and what we do is we do a high volume spinal tap. We go in base of the spine and the lumbar spine and pull out 30 to 40 cc's of spinal fluid, and that way we're kind of doing the compensation for the brain. The brain is making the spinal fluid, but because it can't absorb it at the same rate, we're going to go ahead and absorb it for them. We're going to pull it out. If the brain cannot adjust and hydrocephalus occurs, there's increase of fluid in the head that leads to typical symptoms like we have after surgery. It can lead to headaches, visual changes, nausea, vomiting, mental status changes, somnolence, stupor, and then obviously bad things can happen. People can die if they have untreated hydrocephalus, and that's when we manage usually with a shunt. So monitoring for mental status changes is extremely important when it comes to concern for meningitis, hematoma, hydrocephalus, seizure. All of these things are possibilities after skull-based neurosurgery, or really any cranial surgery. Let's talk about decompensation of the cervical spine. When we operate, let's say we're doing a surgery where we have to turn the head, because this is the area that we're operating. Somebody can come into surgery just fine. They have no complaints of neck pain or numbness or tingling or weakness in their hands, but we operate, their head is turned for 8 hours during the surgery. It is possible that someone who had some arthritis or compression of a nerve root, or even some sort of arthritic changes that were pushing on the spinal cord, that we could have decompensated them during surgery because their head is turned. So if someone recovering from neurosurgery complains of new onset numbness, tingling, weakness, loss of dexterity, we have to look at the cervical spine, because it could be that positioning during surgery has affected that. Now, most of the time, the positioning during surgery, it could be compression of an IV or the way that their arm was turned, but we always want to make sure that anything where the patient's really complaining of some new changes, that we evaluate the cervical spine. We're just about almost at the end, a couple more things to go through. So I want to talk about just brain fog, right? Anytime you open up the head and expose the brain to the elements, to the air inside of an operating room, people will usually feel some level of brain fog. So if a patient's typically, type A personality, able to move and groove, manage a keyboard, chop vegetables, navigate their kitchen and their life pretty quickly, and they're spunky, that's not how they're really going to be for those couple weeks after surgery. Everyone feels like a little subdued, a little bit longer to make decisions, not as quick moving. So what we call brain fog, did I have lunch yet? Where did I put my keys? Did I take my pills? That's actually pretty common. So writing things down, keeping notes, did you take your pills or not? If you have a thought that comes to mind, you might want to write it down, because it's extremely uncommon to feel really sluggish and kind of foggy. Very, very normal. Now, if it's significant and worsening, it could be something like seizure or development of meningitis or something else bad. But if it's, generally just a little bit of a fog, that will clear up in time. So as a team, whether you're a nurse, a family member, a friend, or anyone taking care of or rounding on patients in the hospital. Things like these are the things that we need to make sure we're monitoring. Monitoring neurologic checks, neurologic exam. Specifically, are they alert and oriented to who they are, where they are, what the date is generally. Not everyone gets it perfectly if you're stuck in the hospital for a long time, but they can get close. And then the fourth, if you use a fourth, is why they're there. Vital signs, ins and outs, what they're drinking and what they're urinating. That is by far one of the most important things with anything near the pituitary gland, is the lowering or the rising of the sodium as it relates to the pituitary dysfunction. It can be very, very dangerous for someone to have very low sodium. So monitoring ins and outs in real time and in real time. If someone went to the bathroom, if you're logging it 6 hours later, that's not helpful when we're making endocrine decisions in real time. Drain outputs, logging when the person's getting up and walking, pain levels, looking at the surgical incision, making sure there's not a lot of pressure on the surgical incision, which can be hard for a lot of the surgeries that we do, because this is exactly where the pillow lays. So just making sure there's a little bit of movement, sitting up and walking. Things to keep in mind for the neurosurgical patient: stay in their line of sight. If someone has double vision or doesn't have vision on this side, you don't want to be standing on that side of the bed. If someone has good hearing on the left and no hearing on the right, you want to be making sure you're talking into the left ear. Patients should be sitting up in bed when they eat. I mean, everyone should be sitting up when they eat. So either in a bed or a chair when they're eating, because any sort of lower cranial nerves can make it very difficult for patients to swallow safely. But even if there aren't any cranial nerve problems, when you have surgery on or around the brain, you're sleepy and tired and cranky, and simple things like swallowing appropriately can be quite difficult. So sitting up straight is extremely important. We want to avoid Valsalva maneuvers, any maneuver that causes increased pressure. So if you're straining with the bowel movement, we want to make sure our patients have soft stools. So any transnasal surgeries, we don't want them sipping out of straws. We want to make sure that they're not straining with bowel movements, that they're not lifting anything heavy, any jolting activities. And for us, at least here at Mount Sinai, the last thing is wounds, right? Any wounds that are sewed up are usually sewed up with a chromic suture, which is an absorbable suture. And that would need to start getting washed and kept clean on post-op day 3. However, we also have wounds that are closed with other sutures that are not absorbable, like Vicryl. Again, those can also be washed on post-op day 3. A lot of patients and a lot of nurses get a little bit nervous about telling patients to wash their wound. Keeping the wound clean and dry starting 3 days after surgery is the best way to prevent a wound infection. If wounds keep the crust on them and bacteria develops and it adheres to the suture, that can actually erode away the skin and is more likely to have a wound breakdown or a wound infection. So I hope this was helpful. If you guys have any questions, you can either send me a message through here. You can send me a message through my Instagram at Brainy Leslie or through my website, brainyleslie.com. Happy to help. This is, some pretty basic information here for a skull-based neurosurgery patient and the way that we kind of do things here at Mount Sinai. I touched the tip of the iceberg here. There's so much more that I could have gone through today, but that would be me talking for many hours. So I hope this was helpful. Thanks for taking the time.